So what are we going to do when things don't work out? And so, you know, how successful are resection arthroplasty procedures? And if you look at the literature, and here's just a typical example, and these come out, and there's been at least one or two every year that I've looked at this and say typically 94% of the patients were satisfied, as in the study that looked at the history of Jesse Jupiter's clinical experience and with a resection position arthroplasty shown here. But the question that's always raised by that is, what do you do about the other 6%? And in all of those articles, and this is true, in all of the articles on this, nobody talks about what they did with their failures. They just talk about the 94% of patients that did well. And I can tell you that the 6% are coming to my office, and that's what my practice really consists of. And the same thing is true of elbows. But, you know, so what comes of them? Well, out of those people that you saw on that previous slide, you know, the dashes are high. They have to modify their work activities. They've had multiple procedures. Their pain scores are always elevated. They have pain with pronation and supination, especially when holding anything greater than 5 pounds. And in this illustration that comes from Louis Schecker and from Lee, and an article by Lees and Schecker, who demonstrated the impingement that occurs when the stable ulna is impacted by the unstable radius. And it's not the ulna that's unstable, it's actually the radius that keeps flipping back and forth and grinding into place here. And so, you know, I will agree that all resections will lead to impingement, and not all impingements are painful. But when they are painful, it's a significant change in your life. You know, and so to that end, we go back to this concept. And so Dr. Kennedy mentioned this article, and I have it here again for all the residents and fellows and anybody in the audience that wants to have a copy of or look at this citation. This is an article that is well worth reading. I will tell you, it's very dense. And so you learn a lot per page per paragraph in this particular article. But they did divide everything up into bone deformities, unstable ECU, the TFCC, cartilage defects. And with that, they would then break up and address issues that, in this case, it's a bone deformity with cartilage defect, no cartilage defect. There's a non-repairable or reparable TFCC tear. You know, is there anything in there? No, it was just the bone deformity. And to that end, this unstable distal radial ulnar joint will be directly impacted by the osteotomies that we saw in previous lectures. And then you could add to that, what if we have bony deformity and a TFCC tear? It means that you have to address both in order to get a stable joint. So what happens when you got all of it? You have a bone deformity, you have no cartilage left because it's been resected. The TFCC injury is floating in place, and you have an unstable ECU. Well, here's an example of that, and will lead off for us. This is a patient of mine who in 1995 had a resection, and that is a silastic cap. Tom Fisher and I are certainly old enough to have seen a few silastic caps in our practices, but those are no longer used. This was replaced in 2000 by a semi-head that then evolved into what you see in 2008 and is accompanied by increasing pain, discomfort, and dysfunction. So what are our choices? We could do nothing, just ignore it and get better. And we know the outcome of that from 1856 to 1860. We could do increasing distal resection, so as quicker is better. And this was a case series that was presented by people that are really, really smart and very good. I've never had much luck with this, although some people have and continue to. When you can't do anything else, we can create a one bone forearm. And I have a series of these that have been recently presented in hand clinics, but it actually becomes a more and more of a go-to procedure in patients that are just miserable, and I can't think of a thing to do for them other than creating a one bone forearm. And is a moderately satisfying experience for these patients because it increases their activities and they do better in life. We could do a repeat interposition, and this was popularized by Dean Satirianos in an article that has appeared in 2018. And he looked at a number of patients in which he took a piece of allograft, in this case, Achilles tendon, interposed it between the radius and the ulna, and you just find it stuck in there in place, and he held it in place. And those results were really remarkable. He had improvement in their VAS scores, pronation, supination improved, grip strength improved. There was only one failure, and there's one fracture. He had 3 patients who had this scalloping that occurred, and I've got a couple. I've done this procedure in younger people with Madelung's deformities, and they get this scalloping thing, and I'm just waiting for that base of that scallop to break off sometime, and I don't know what I'm going to do with that, but I think that it may happen. But this was his 2-year results. So this leads us to semi-constrained arthroplasty, and semi-constrained arthroplasties were introduced to us by Louis Schecker. And in that article by Carr and Garcia-Elias, when they said we've got all of this, all 4 entities are injured and destroyed, there was only one device or one procedure that they thought could address it and still have functional pronation and supination. And that was a semi-constrained hemiarthroplasty shown here. And it's called the Schecker or the Aptus semi-arthroplasty. Now, when they presented it, they presented 46 patients, of which I examined a lot of these patients and had the opportunity to do that. And they had remarkable improvements. They had 1 failure, 1 fracture, and reported 2 out of 46 patients as complications with a 5% complication rate. Well, I have this friend, his name is Peter Stern, and he makes a living off of looking at complications, and everything can be a complication. And if we put this to the Peter Stern test and took the article apart, the complication rate goes up to about 40% because there was a number of smaller complications, but there were still complications nonetheless, and it sits at about 40%. And that prompted us at the University of Washington to look at our cases in about 50 plus cases. And this is the work, these patients were my patients and my partner's patients, Jerry Wong. The article was put together by Kate Bellevue and Kate Thayer and Mike Julio. And what we found is that our complication wasn't quite as high as the complication rate that was presented at the same meeting in the Mayo experience. And I'd like to go through how I address those and what I think I learned from this experience. And I will say right now that I continue to do this operation. So, what's changed for me? Well, the first thing that changed for me is that if you avoid using this standard stem, the size 30, and use a 1 centimeter stem, then you won't run into issues with heterotopic ossification. So that's our standard. 2 is that you got to keep your patients from using this extremity to pound things on a repeated basis. And I had 2 cap loosenings in people that went back to foundation carpentry. But in order to address cap loosening, what has happened is that the device has been changed so that loosening is much more difficult because of the way that the cap is introduced. And if ever you're using this device, introducing the screw as shown on your far right And just bringing it down makes it a lot easier to put that on and put it in place. In the technique manual, they talk about moving this device quickly. And in our cases where we had adhesions, we had other things going on in the wrists, such as fusions or tendon reconstructions. And in the cases that we had adhesions, they were immobilized for longer than 72 hours. The other thing that we found is that if we did interpose a piece of material between the implant and the tendons, you will get tendinitis and tendon irritation. And this is just shown in raising this particular retinacular flap. It is raised and then it is interposed between the extensor carpi ulnaris and the implant itself. And then we had 3 late infections in this particular case. The thing that we learned from this is in 2 of those cases, they had had dental extractions or dental manipulations within days of becoming infected. And the case that I show here, this is at 7 years, 5 to 7 years. So I'm sorry, it's at 7 years. After a successful implant, he had a root canal. 7 days later, he has an infected joint. And my partner, Jerry Wong, was very nice to be the guy that took this apart, put beads in place on a Christmas Eve, and then I reconstructed it 6 weeks later. I had 1 permanent explant in a patient who has had residual infection and should not have been done in the first place. And this is an error in judgment on my part. And that was treated by conversion to a 1-bone forearm. We had 3 cases of neuritis that we dealt with. 2 of them were pre-op, and in those cases, we did neurectomies and buried the dorsal-cutaneous branch of the ulnar nerve and soft tissues proximally. One of them was a traction injury that I did that was iatrogenic on my part that resolved after 3 months. We found that if you have arthritis of the elbow, especially the proximal radial ulnar joint, it will be revealed by this procedure as the increased motion and function of the distal radial ulnar joint improves. The irritation of the proximal radial ulnar joint will also be revealed, and this prompted a revision of this particular elbow in this particular patient. We had 4 stress fractures, all repeated. All were related to impact loading, 2 because of demolition. One was wood splitting, and one was you doing old style car, car racing. Each of these stress fractures occurred within the first 6 weeks of the procedure. And as such, I really admonish people not to do that and not to use those as such. So I think that this is still a very good salvage procedure. It shares the forearm convergent load. It prevents volar and dorsal translation. It follows the forearm axis of rotation. It stabilizes the wrist on an otherwise stable ulna. It does demand attention to detail. And I think that if you pay attention to your complications, you will improve on your next set of patients. So this is not really an easy procedure. It is a detailed procedure. So in this particular case, how did I treat it? I did remove the ulnar component, replaced it with a aptus reconstruction, and she is here at X-ray, and she does have a now complication. She has irritation from her wires. So I will, at her choosing, I will be taking out those wires sometime in the next couple months. I saw her a couple months ago, but she continues to do well. So that's that lecture.